Hello, everyone. My name is Katarzyna Kotulska. I'm the pediatric neurologist from Warsaw, Poland, the Children's Memorial Health Institute. And I had the privilege to lead the clinical work package in the EPISTOP trial, which has been just published. With the EPISTOP, which was a multi-center trial carried out across 17 clinical sites and laboratories across Europe, Australia, and the US, we were able to demonstrate that early intervention with the preventive treatment of epilepsy in tuberous sclerosis infants reduced both the risk and the severity of epilepsy. In terms of severity, I meant not only the frequency of seizures and the risk of drug-resistant epilepsy, but also the risk of infantile spasms. In the infants who were treated preventively at the onset of abnormal EEG, not waiting until the clinical seizures are there, we were able to prevent infantile spasms. We had no single infant with infantile spasms in the group of infants who got the preventive treatment. It is very important because infantile spasms are associated with the majority of neuropsychiatric comorbidities of epilepsy in TSC, but also with the higher risk of sudden unexpected death in epilepsy. Infantile spasms in TSC are generally preceded by the focal seizures, and the importance of the early recognition of focal seizures has already been discussed. But also the importance of the early recognition of infantile spasms is very important because it is well demonstrated that the earlier you treat infantile spasms, the better is the response to treatment. Another important thing is that the dosage of the drug and the recommended first-line treatment for infantile spasms in TSC is vigabatrin is very important. So the higher doses, the doses between 100 and 150 milligrams per kilo per day is associated with better response than the lower dosage. Moreover, the higher doses are also better in the prevention of the recurrence of infantile spasms. So if you have a child who responded to treatment and you want to sustain this response, you have to use the higher doses. The lower doses are much less effective. In epilepsy treatment is to keep the medication for at least 2 years of the period when seizures are not there. So if the patient is seizure-free, you have to keep the medication for 2 years. And that TSC is not an exception of that rule. Moreover, in symptomatic epilepsy, sometimes this period is recommended to be longer, not 2 but 3 years. And the preventive treatment is not the treatment of patient who has no epilepsy. The preventive treatment is the treatment of patient with epilepsy, but in pre-symptomatic period. So we shouldn't withdraw the medication after six months or when we think that it's no longer required. It should be evidence-based, so we shouldn't individually adjust the treatment in the patient to our feelings. You have to remember that the patient with TSC requiring treatment is a patient with epilepsy and should be treated as all the epilepsy patients. Sudden unexpected death in epilepsy is sudden and unexpected. So you cannot explain it with other causes. And what is important, it is not always preceded by seizures. So it's really very, very difficult to predict. It occurs in about 1% in 1,000 people with epilepsy per year. But it is much more frequent in people with drug-resistant epilepsy and with the epilepsy patients with the epilepsy onset in childhood. So children with infantile spasms are much more are much at much higher risk of SUDEP than other children, other patients with epilepsy. So the prevention of infantile spasm is very important also in terms of the prevention of sudden unexpected death in epilepsy.